don't know what the final image is. If you've ever done that, it's really hard. You gotta know where to start. And I think of it a lot like this, that all these variations in our system and like what we've experienced is a lot like a missing picture. And so we can bring it all together and then start to see the bigger picture here. So here's my son, Dylan, this summer in Sevilla, Spain. We had a wonderful time. But when we see the big picture, parents can get better answers, understand kind of what all the words mean. We can speak a common language and we can come together to try to figure out how to improve this and kind of create some standards and some guidelines around it. One of the first things we were told, excuse me, when we were diagnosed, the first thing the fetal cardiologist wanted me to know when I had a bajillion questions was that no two cases of HLHS are the same. And while I understand that because there's difference in anatomy and surgical journeys as such, we kind of just have anticipated and expected a lot of that variability along the way. But what if we challenge that? What if we create more of these guidelines? What if we create more plans, kind of reduce that variation like we've done so many times already, and if I might say done well, and we can challenge those norms. And what if we can improve quality of life? And what if we can improve survivability and also Fontan longevity? So I'm really excited to be a part of this panel today and hear what we have to discuss. So without further ado, I will introduce Dr. Oye, who is going to go over the first case study. Thank you so much.
Thanks, Lacey, and thanks, Dr. Allen, for inviting me, and to Ty, one of our patients, for inviting me. It's great to be here. It's great to see all these people here, a lot of people I know. It's nice to see my colleagues, some new colleagues, some older colleagues, and I wasn't referring directly to you, Gwen, on that, and see former fellows and a lot of faces that I recognize. So it's a real pleasure to be here. So thank you very much. So the part that I'm going to do right now is called What is the Problem and Concern? I'm going to talk a little bit about the prevalence and maybe a little bit about the mechanism, and then I'll pass it off to Mike. I have no disclosures pertinent to this talk. So like I said, we'll talk a little bit about the background, a little bit about the prevalence and the progression of tricuspid regurgitation, or at least what we think we know about it, and a little bit about the mechanisms. So as background, Norwood survivals are 90% plus in experienced centers. 5-year survival is probably around 75%. So not great, but we continue to strive to get better with things like this right now. The risk factors for stage palliation are well known. They're obstructed pulmonary venous return, and I won't go through all of them. But if you look at the very bottom, it's tricuspid valve regurgitation. And that's of interest to us as surgeons, because that's maybe something that we can impact. We can't, as a surgeon, impact the birth weight, and we can't impact the genetics of it, but we might be able to impact the tricuspid regurgitation. So for me as a surgeon, we think a lot about tricuspid valves. So the SVR trial, what is the prevalence of this? It's surprising. It was very surprising to me from the SVR trial, and I think most people in this room know what it was, but it ran from 2005 to 2008, and we enrolled 555 patients with hypoplastic left heart syndrome or other related single right ventricle lesions that were going to have a Norwood, and randomize them to either a BTT shunt or an RV to PA shunt. And this was really surprising to me that 19% had moderate or greater tricuspid regurgitation, so significant tricuspid regurgitation at 12 months post-randomization. Here's our Fontan experience that we published fairly recently, over 1,100 Fontans. Of those, 675 were single right ventricles, and 19% underwent a tricuspid valve intervention. Granted, we're fairly aggressive about fixing tricuspid valves at Michigan and intervening upon them, but that's still a very high number. And you know it has to be higher, right? Because there's other patients that unfortunately don't make it along the way that have TR. There's patients that have TR that don't get intervened on. So these are only the patients that got intervened on. So in our Fontan population, it's going to be clearly over 20% of patients had significant TR. Here's just one other study from another center, a European center in München. This was 434 patients, 51% had a single right, and incidence of moderate or greater TR 37%. So a remarkably high number, and it's different from ours, but ours, again, remember, was interventions only. So what are the mechanisms? So there's lots of different mechanisms that can happen with tricuspid regurgitation. There are anatomic abnormalities. Is there a problem with one of the leaflets? Is there a popped cord or something like that? And it can be acquired. And if you look at how all these things interact, they all interact with each other, and it can be sort of a vicious cycle. And I'm not going to go through all of them, but if you think about it, if you have TR, you have volume overload, that ventricle dilates up, the annulus dilates up, you get more TR, and that becomes a cycle around. So there are lots of different mechanisms, both acquired and inherent. So I'll stop there and I'll pass it over to Mike.
So thank you, Rick. As I mentioned earlier, I'm adult and pediatric trained. Spent probably the last 19 years of my life really focused on adult congenital. And since my arrival in Chicago about 3 years ago, we're now seeing 60 to 70 patients a week. So I want to share a little bit of how what AV valve regurgitation means to me and the adult patients and the long-term follow-up. And Rick just showed really short-term, but I want to really bring it all together and what this is, how it means to the long-term picture that what we know today. I have no disclosures as well. I think when we talk about the impact of AV valve regurg, we got to really understand some of the basics. And there was an animal model studies all the way back in the 1940s that looked at it and said, you did not need a subpulmonary ventricle to survive, but you needed to have low filling pressure, and you had to have low resistance in the lungs, and you had to have sinus rhythm was a really made key. The minimal pressure gradient between your lung pressure and then your heart was 6 millimeters. And this is a really important number to remember. So even in the 1940s, this was known. We all know this, we don't have to rehash it, but Dr. Fontan presented this 1971 was the paper, but he did this in 1968. And the Fontan procedure we did back then, the first one was very different. The thought was the atrium would be a pump in the system. There's 2 valves in the system. The pulmonary arteries were disconnected that you can see in this diagram. But since that time, it's now had multiple variations. The medical care has changed, the surgical care has changed, and it's been applied to almost every form of single ventricle, including hypoplast. And the survival has incredibly improved. And this is Dr. Rychak's going to talk next, but this is from one of his white papers in 2019. And this is showing you the different eras and the different colors. And you can see 1992 and then 1970 to 2002. And you can see that the survival continues to get better in each era because we're getting better at it. And we're changing the modifications. And this is exciting news when you look at this. But you still see that they're all downtrending, correct? There still is a dropout as we go. So we still have a lot of work to do. When you look at the current era, and Dr. Roy just showed this, again, early operative survival is really good. And so early operative survival is not long-term survival. And that's what we often have to think about in adult congenital. And then the paper in 2002 with Dr. Gaynor, 97, 99% at 1 year survival. And in that series, 53% were hypoplast. So a huge step forward in the modern era that we're seeing. And so those curves should continue to get better with a 10-year survival now of 90%. And we now have about 70,000 Fontan patients worldwide. 40% of those patients are 18. So adult congenital programs are seeing these over and over and over, and it's a growing population. And now many of them have hypoplasts. And so we're seeing these single RVs in our clinics. The causes of mortality, when you look at this, my colleague Paul Carey really published this in 2008, looking at the Boston data, but heart failure, not surprising. You have a single ventricle doing the work of 2. And again, but it's not just systolic squeeze. The pressure rises and the ventricle gets stiff. And then thromboembolic events, clotting, and then sudden cardiac death. When you look at risk factors for mortality, obviously the whole session's titled what we're going to do with the tricuspid valve regurgitation. But the risk factors have been published multiple times. But each era, they're similar, but there is some slight differences. But AV valve regurgitation and having repair is one of the things that continues to come up in all the different eras that we're looking at. And obviously, RV versus LV, early on, some of those series clearly show RV do worse, but more recent data says that at the time of Fontan, RV and LV dominance is similar in outcomes at the time of Fontan. Great step forward for us. And then other causes. So let's talk about AV valve regurgitation. It's been known, even in the original papers by Dr. Fontan, that having more than mild AV valve regurg was a risk factor for survival when you did the Fontan procedure. Some of these other ones highlighted, these are things that are really, really high risk. Again, these are typically ones that are not modified, but AV valve regurg is not considered an absolute contraindication anymore. And really, most are considered modified, except these 3 that were underlined. So even early on, we knew that AV valve regurg was a problem. And we've known this since we started the Fontan adventure that we've had. So when you look at the big series that have been published, and this is one of the papers that we're going to talk about, this is really looking at the Australian and New Zealand registry. And it's a modern series, and that's why I like it, but it has long-term outcomes out to 37 years. So it's really important. And what this shows you is that over time, AV valve regurg increases the prevalence of it over time. And again, you can see the 5-year rate, 7, 12%, and at 20 years, 21%. And you can see in this series, there was 130 that had common AV valve. Those are kind of patients with heterotaxy, but 97 had tricuspid valves in this series. And so this was a really important aha moment. So it shows that it progresses over time. But valve type does matter. And this is where this paper and several other papers have really shown. And in this paper, if you look at the cumulative incidence of AV valve operation or moderate to severe regurg, and we consider this failure of this valve, when you get out to 25 years, 56% of those people at 25 years have already developed AV valve failure. If you look at, and that's the blue line there with common AV valve, but look at the mitral valve. This is the one, so if you have mitral atresia, the 46% is that group that we're talking about. Mitral atresia, by definition, you have a tricuspid valve as your AV valve. But compared to the 4%, which is these patients that have a mitral valve as their AV valve, look at the difference at 25-year risk for follow-up. And this is similar to data published in 2020 by a really big series by Dr. Moon. And he showed that if you had a morphologic RV or a tricuspid valve, you had an increased risk for AV valve failure. And then the group from Mayo in 2020 looked at theirs, and they also found that if you had a tricuspid valve, you had an increased risk for failure over time of that AV valve. Well, that's good, but what's it mean? Well, if you have AV valve failure, when Dr. King and in his papers and the group there, when they looked at it, if you had AV valve failure, it also predicted Fontan failure. And Fontan failure meant either class 3 or 4 heart failure symptoms, transplant, Fontan takedown, protein losing neuropathy. And if you look at this at 10 years and 20 years, and you look at the no valve failure in the blue versus the red, clearly AV valve regurg predicts those that are going to get in trouble. And you can see this on this slide. So at 10 years, it was 94% of those patients that had no valve failure were doing well, and 77% of those that had now Fontan failure if you had valve regurg. And then if you get out to 20 years, now there's 54% of those patients that now had Fontan failure if they had AV valve failure as well. So again, predictive. And this is what other people have shown. The paper by Dr. Moon, again, if you had greater than moderate regurg, it predicted ventricular dysfunction. So the chicken and the egg thing, this shows this. This is a big focus, and that's why we're talking about it. But this is the long-term data, and I think it's important. Well, what's the impact? What does it do? Well, if you have increased volume load because the valve is leaking, that leads to the ventricle dilating, the contractility of the ventricle eventually goes down, filling pressures go up, central venous pressure goes up, liver congestion goes up, liver fibrosis, and then you can have end organ perfusion issues. In the end, all that fancy terms, it's bad. Okay, we changed that gradient that we had between the central venous pressure and the filling pressure. And over time, you definitely can have decreased function. The problem with measuring AV valve regurg is because it's really dependent on your blood pressure, your heart rate, and your volume status. And so any given time, if you follow kids, it can change a lot. So mild, moderate, severe, you can see a big difference. And that makes our job really hard. Medical therapy, I'd love to tell you that I have the magic cocktail. Dr. Allen, where's she at? We got to find the magic cocktail because we don't have it, okay? Medical therapy in the setting of Fontans, everybody uses this term guideline-directed medical therapy. We don't have it in Fontans, but I'm hoping that we can. We have RVs versus LVs. We have Fontans that have different AV valves. In the end, the other thing I want you to know is that the function of the ventricle doesn't always correlate with exercise tolerance and Fontans. And so this makes our job really hard in clinic because I can see somebody with a really bad function and their exercise tolerance is reasonable. So there's other factors, your lung function, restrictive lung disease, your heart rate, how it responds, all these affect your exercise. And pro-BNP doesn't correlate as well. Even in patients that have great Fontan physiology, they're about 70% predicted for their age, which is good. And there's no data in the use of medical therapy for after reduction in AV valve regurgitation. We know this in 2 ventricle patients. If you have a leaky aortic valve or mitral valve, medical therapy has never shown to change the outcomes in those patients. So to think it's going to change the outcome in a single ventricle, I think it's a long shot. It may help temporarily, but it's not going to change the long-term outcomes. Loop diuretics, so diuretics we often use, you have to be careful. Remember that 6 millimeter pressure difference. Aldactone is another medicine that often helps with decreasing fibrosis of ventricles. It also helps if you develop ascites and also goes along with protein losing and neuropathy. ACE inhibitors, many of your children may be on it, but lisinopril and enalapril, all the prils, and then the ARBs, losartan, valsartan, irbesartan. There's really no benefit in the setting of a systemic RV in any of the studies. There may be benefit in the setting of an LV with a Fontan, but not with an RV. We use them all the time, but it doesn't mean there's outcome data. So you have to balance those pressure differences and side effects and how they're actually feeling. Beta blockers, we use these often in arrhythmias, but again, they're small studies that show that there may be a change in ventricular size, but long-term really showing you that there's a major difference is not there. And Entresto, you probably see all the commercials at halftime on the football games. Again, this is a new medicine that has a lot of new interesting potential impacts, but small studies only right now. But the early studies have been promising. And then SGLT2 inhibitors, Jardiance and Farxiga. These are medicines that actually may have a really interesting role in the setting of Fontans. They may have a kidney protective effect as well as a liver protective effect. And it does something very interesting. It changes your metabolism at the cellular level to use ketones. And does it decrease free radical formation? These are fancy things, but it's really kind of one of these things that we really don't know how they're working, but they seem to be protecting organs. I'm going to turn this over eventually to Dr. Roy here, but this is where I'm going to give you the long-term version really quick, and he's going to give you the newer version of it. If you've had an AV valve repair, okay, it shows that you can get them to the Fontan. So high-risk patients, we're getting them out to Fontan now, and that's a success story. But if you look at the long-term data, it still is a major risk factor in almost every series published. If you've had your AV valve repaired, anytime in your stage of your Fontan, it is a risk factor for long-term mortality. And this study was published in 2017. It was a meta-analysis, 6,707 patients, and again, clearly showed that it was an independent risk factor if you had repair or replacement. Dr. Roy showed you this earlier a little bit, but this is from the reconstruction trial, and I'm going to show you the long-term part of this. I don't consider 6 years long-term. I consider 60 years long-term. So in this study, when you look at the short-term, stage 1, if you had to have your repair of your AV valve at that time, that's a sick kid. And you can see that in the red, stage 1 intervention, no intervention. So that means if you had to have your valve repaired or not, there's clearly a survival difference. If you required repair, you had a worse outcome. Stage 2 is when you had the Glenn. Now, the whole idea of the Glenn is that it unloads the ventricle, it protects the function, lowers the filling pressure, and if it does that, it may protect the AV valve. That's the whole idea behind it. And it was actually proposed for hypoplas, and now we do it on every Fontan because we think it works. But when they looked at if you needed a valve repair at stage 2 or not, again, there was a mortality difference. If you had to have your valve repaired, you did worse than those that didn't. So again, a really important thing. Now, the interesting thing is if you look at Glenn's anyway, the AV valve often gets better even if you don't do surgery. So 46% of the time, the degree of regurg gets better if you don't even do anything. So do we need to repair? These are things that people are talking about, and I don't know the answer. Fontans, if you had to have an AV valve repair at the time of Fontan, in general, in the olden days, because we had a lot of different Fontans, it was bad. And clearly, if you had an RV dominant, so a tricuspid valve, you're a higher risk. And this is the Mayo series in 2020. And again, more importantly is if you have a Fontan and you have to have your AV valve repaired after you have had a Fontan, the mortality is really high. And every paper has ever published that. The King paper showed that the mortality at 3.8 years was 40% if you had to have your valve repaired after you had a Fontan. So again, important data that we're looking at. But again, this is really important. But I don't want gloom and doom because our surgeons are outstanding. Our surgeons are getting better. And he's going to show you this data that he has and kind of some of the repairs because I think it's important. But recently, if you take people that are surviving the Glenn, even if you've had valve repair or not, And you actually look at what happens when they're at Fontan, their survival is the same. And so it's telling us is that we're getting better. And there's several really nice papers. This paper in 2014 looked at the detailed mechanics of AV valve regurg. They've done MRIs and they analyzed every different thing you could do. And what they found is if you really focus on the mechanism of these, and this is where we're going to hear from Rick again to really talk about some of these repair types, what they're finding is that in the current era, and there's a paper now that showed the 5-year survival after AV valve repair was better. And it actually was the first time I've seen that paper. So I've showed you some negative stuff for adults, but I will tell you is that there is some good things coming. What I will tell you though is if you have heart failure and you have AV valve repair, we're late, especially if you're an adult congenital patient. If you're an adult congenital patient and you have AV valve regurg and you have heart failure, the mortality of AV valve surgery is too high. And in those cases, that's where we often move the transplant. We've now done 9 transplants in our center in the last year on Fontans, 5 heart and liver. We now have 10 listed at our center now. It's one of these new arms that we're doing. I'm very passionate. I love what I do. But again, I'm hoping that the next generation of our surgical repairs are going to have better outcomes than these. And remember, these are all comers, right? But I'm really hopeful that our newer repair techniques that we're going to share with you are going to do much better for our groups of patients. So thank you for your attention.
Glad to see I'm not the only person that tripped over that light. Well, that was perfect. I think these are really dovetailing really nicely together. And I wish I was going to get up here and say I'm the cavalry and I'm going to show everybody how we're going to fix all these valves and everything's going to be perfect. And I think we're working on it, as Mike said. I think we're getting there. As he also mentioned, there are now some results that show that we're actually maybe for the first time improving outcomes with tricuspid valve repairs. And so I'll go a little bit into the surgical management. It's just going to be a little bit more granular. Mike's already gone over some of the longer term results, but I still have no disclosures, although I am available for financial gain. So you saw the slide already about mechanisms. And so we talked about that there are anatomic reasons, and then there are acquired reasons for regurgitation. If you look at this slide, there's really not a whole lot of places that we can intervene as surgeons. You know, I can't affect the PVOD. I can't affect arrhythmias. I can't do a lot of things, fix diastolic dysfunction, but I can fix anatomic abnormalities. So from a surgical standpoint, that's one place I can intervene. And maybe the other place I could intervene is annular dilatation. And that's been kind of a common theme throughout much of this, that part of the problem is annular dilatation, right? The ventricle dilates, the annulus gets bigger, and those leaflets get farther apart, and that begets just more leakage. So just to talk very, very briefly, you know, this isn't a surgical talk, but what we do is generally a partial annuloplasty. We just take the tricuspid valve and obliterate that posterior leaflet and make it into a bileaflet valve. I kind of joke with the fellows. I tell them, when you go in there, this is how you repair it. You fill the right ventricle with saline. You look for where it's leaking. You examine the anatomy, figure out what you think the mechanism is, and then you just do a partial annuloplasty. So ignore everything that you see and just do that. And it's fairly reproducible. I mean, I've literally talked to people the morning of surgery. One of my colleagues from another hospital called me, hey, you know, can you tell me how to do that? And then I told him, well, this is what we do. And he went and did it like 15 minutes later. And then he called me that evening. He's like, oh, it worked great. It's perfect. So that's our go-to. So what are the outcomes of this? So these are our outcomes from Michigan. This is a little bit dated now, but we looked at 28 patients and a mean follow-up that was limited. Mike gave you some of the longer term, but this is median follow-up of 20 months. We had 27 of 28 patients that we were able to locate. So let's look at the outcomes of those 27 patients. So if you take those 27 patients, 17 patients had a successful repair as defined by 0 to 2 plus TR. So basically up to mild to moderate-ish, and 30%, 37% or 10 patients had a bad outcome defined by moderate or greater regurgitation. So of those 17 patients, and these 17 patients and the 10 patients you're going to see come again and again in the slides, and I tried to color coordinate it as well. So of those 17 patients, 15 had a single valve repair to get to their successful state, and 2 had a second repair to sort of rescue them back to a successful repair. The 10 patients who had a bad outcome, greater than moderate, so there were 6 early successes, and then they went on to late failure. And there were four early failures. Right out of the box, the valve didn't work well after repair. So let's drill down farther now into understanding why did all this happen? Who ended up in which box? So of the 17 patients, their outcomes, if you looked at what happened to them, 15 went on to successful Fontan. Of those 15, 14 were long-term survivors. One was a late death from a non-cardiac cause. Two are still at their hemifontan or were still at their hemifontan. One was awaiting Fontan, actually has had a Fontana, and the other has been transplanted. So of those 17 patients, 15 went on to Fontan successfully. So here are the 10 patients that had poor late tricuspid valve function. Of those patients, those 10 patients, 8 unfortunately died. 2 were early deaths, meaning close to the time of surgery, and there were 6 late deaths. So it's really a bad thing to have. 2 actually went on to their Fontan, one with a mechanical valve replacement, and one with a re-repair, although that patient still had moderate TR. But as Mike said, some of the times these patients do fine, and that patient actually continues to do well. So let's look at the durability. How did you end up in those boxes? So the numbers you see there, 21 and 6, so that's early post-op. So that's basically in the operating room at the time of discharge. 21 patients had a quote-unquote successful repair. 6 had an unsuccessful repair right out of the gate. And so what happened to them? So of the 21 patients, 15 had a durable repair. Of them, 6 had a late failure. So 21 initial successes, 6 failed late. Of the 6 who had poor valve function early on, 4 continued to have poor function, get you that 10 number. 6 we rescued with a second repair and pushed it up to the 17. So there's your 17 and 10 again. So how did you get it these way? How do you get to the different arrows? Of course, we want everybody to get up to the green, but how did you end up on the different tracks? And what does that tell us about who we should manage in different ways? So one thing that Mike touched on again, and so it really this dovetails super nicely. So RV function is super important. It's not just about the tricuspid valve, it's about RV function. So this is on the RV function graph. So it goes from poor to good at the top. And this is in the immediate post-op period, or sorry, the pre-op period, the post-op period, and then at last follow-up. So green again are the patients that did well. Red are the patients that ultimately did poorly. So of course they all start with fairly decent function pre-op, but then you see post-op, there's a group that immediately in the post-op period, despite a successful repair, drop down to have bad RV function in the immediate post-op period. And of those, you can see there's a lot of red on that group. And then at last follow-up, those with poor RV function continue to have poor TR or poor tricuspid valve function. So RV clearly has something to do with it. Late survival, this is what happens if you have TR, and again, Mike had some of these data too in different setting, but there's the 18 out of 27 total patient survival. But look at the difference between if you have a successful repair and an unsuccessful repair, 16 out of 17 versus 2 out of 10. So TR is a bad thing. RV function also plays a really significant part in this. It's just not about the tricuspid valve. Again, there's the overall 18 out of 27. If you look at good RV function, 18 out of 21, bad RV function, 0 out of 6. So it is a bad problem, as Mike said. Talked a little bit about what stage you're at. And as I said, we're fairly aggressive at Michigan about basically anybody with moderate or greater TR will get a repair. And even some, if you're going to be there for your stage 2 or Fontan and say you're mild to moderate, I'll still try to make it better. So this is if you had a late successful repair in the green versus unsuccessful. Basically, the light blue is if you'd had it at the Norwood. So you can see fewer Norwood repairs in the successful group than in the unsuccessful group. But again, this is not really a choice a lot of times. We want to fix them early, in our opinion. So what do we conclude from these data? So we believe that tricuspid valve repair can be performed with very good results in most of the patients, even with significant TR. If you have a good repair early on, it tends to portend a good result long-term. The majority of our patients with early success continue to have late success. And again, RV function is going to be a very important determinant of how the patients do long-term. And earlier need for tricuspid regurgitation or tricuspid valve repair, as you might expect. If you're a Norwood with bad TR, it's a high-risk Norwood. So what do we infer from this? How does this affect how we manage patients at Michigan? So tricuspid valve regurgitation, we feel, is a very reasonable thing to try. in these patients. Repeated repair can also sometimes be successful to help rescue some of the patients who continue to have TR. However, patients that have tricuspid valve regurgitation and RV dysfunction have poor outcomes, whether it's preoperatively. In fact, we don't even do those patients anymore. We direct them directly to transplantation. Our patients in the immediate post-op period who had good RV function, fix their tricuspid valve, their RV starts having bad function. We also move them very quickly to transplant. And so those are, I think, the lessons that we learned from these data and how we manage our patients at Michigan. So now we'll move into the Q&A. All right, thanks. Couple questions. Q&A is.
My question is just, how do you roll mechanical valve into your decision making in this patient population, or do you think if that's what you're going to need for a repair, that's not the right route to go?
Yeah, I mean, it's sort of, I like to think of it as a fallback. We can repair most of these. I think there's only been a handful where we've actually replaced them. Again, it has to be in the setting of good RV function and otherwise good hemodynamics. But we will have that as a fallback, and I'll always discuss that with the patients. Most of the time, we got to come out with a good repair. You can't go in and come back out with moderate or you didn't fix anything.
So the data of long-term for replacement is small. So the numbers are usually small. In that Mayo series, they had 7 total. The Moon paper had about the same. And then the King paper had a few. And what you'll see is that the replacement, if you're replacing the valve, as the surgeons will say, there's always increased early mortality because it's a higher risk group. So there's a lot of factors. So any patient that's had a replacement that I know of in the single ventricle has really done poorly. And that's what the data would show. Now, it doesn't mean that maybe we're waiting too long and maybe we are at a point where we should consider that. But as you know, every valve that we have, mechanical or small is an issue. And then again, I never want to speak for the surgeons, but the apparatus underneath these single ventricles are incredibly complicated. So the AV valve, and one thing that the MRI data has shown us is that the fibers and the way they're arranged and the way the structure is, I really worry about when replacing valves, what happens to the single ventricle morphology. And the MRIs will show you that even in the different stages, the strain and the way the myocardium and the fibers move is different from each of the stages. And I think when you mess with the chordal apparatus, things kind of are going to change a lot. But that's my 2 cents, and that may be why it's not so good.
Yeah, for the parents or those who might not be aware of it, the valve isn't just doors that open and close. It is a dynamic apparatus. It also affects RV function. And we know that mostly from the mitral valve. If you take a mitral valve and you cut it out, take all of the cords and all the apparatus out and put a mechanical valve, it is detrimental to the ventricle. So it actually interacts not only to hold blood and keep it going one direction, but it also has an effect on the function of the ventricle itself. I would say one note about those patients that get replaced, probably most commonly it's for common AV valve. It's not really for, it's pretty rare with tricuspid. And those are really complicated.
Yeah, absolutely.
Over here. Thank you, Rake and Mike and Lacey. Rocky Sang from Texas Children's Hospital. By the way, I wholeheartedly agree with you about the mechanical valve replacement for our single ventricle. It tends to not work. My question is, at Texas Children's, we kind of do the similar things as you guys have talked about. If there is systemic ventricular dysfunction, we typically don't replace or rather repair the AV valve. We shuttle those patients towards the transplant pathways pretty early. My question has to do with what has been you guys' experience with supporting those patients either concomitantly or subsequently with mechanical support? And that's kind of where we are still developing our own algorithm. especially as you just mentioned in the setting of significant AV valve regurg, how we cannulate the inflow and which candidate require mechanical support in the setting of a systemic ventricular dysfunction.
Rocky, good to see you. Thanks for the question. I have to say if Texas Heart is still developing their protocols for mechanical support in these patients, and for those who don't know, they're very well known for their program with mechanical support. I can't say that we have the right answer too. I think we're learning. Also, as well, there are lots of variations of how these patients can be supported. As you all know, now we're starting to use Impellas, for instance. We have, unfortunately, I think less VADs than we had a little while ago, unfortunately. But I think we're on the same journey as you. We're learning as we go. I think one thing that we've all learned is that we have to do things like this more aggressively. We can't wait until the patients are really sick. We can't just wait until the RV gets bad to do the tricuspid valve. We overall, I think, in all aspects of the care of these patients, gotten a bit more aggressive and learned that if you do your transplant too late or you support them too late, it is just that, too late.
Again, I would tackle on that and jump on that too, is just that if you look at the data and you look at the use of VADs in congenital heart disease in general, we're way behind in regards to when do we use them? Do we use them as fast? If you look at the UNOS transplant data, you would find in the past that the use of VAD support in adult congenital was really small, and the outcomes were poor because we were not good at it. So the same things that make a congenital patient high risk for transplant were the same things that made them high risk for VADs, and so we weren't using them. More recent data, though, in centers such as Cincinnati and some of the other ones that have published a lot on this, you're going to start seeing that the outcomes after VAD support of single ventricles are getting better, and it's just because we're getting more experience. So I think your question is great. I look forward to partnering with all the centers to try to come up with the best answer. Personally, I feel that we're always too late. I feel that we often are always doing things later than we should. But as we said before, we don't really have that key piece of the puzzle to decide when we should move to that next step. That's the other piece of what we're really trying to do as these outcome and these registries are starting to look at when should we go to that next advanced therapy for these patients with single ventricle physiology.
Thank you. Sasha Patowski from Cincinnati. So I just wanted to get back to something Lacey had brought up. Sorry, I'm out here. Sorry, just to confuse you.
With the blue
so
shirt.
Lacey mentioned the uncertainty in measurements. And then when we look at a research slide, we have 0 to 2+, 3+, or 4+. And a lot of those people who are 2+ might sometimes be 3+, sometimes be 1+. And most people are probably in the 1+ or 2+ range. And our uncertainty in terms of measurement and communication and our uncertainty in terms of making decisions creates a lot of issues about anxiety and uncertainty and probably lack of trust. How do we address that and think about that when we're communicating with patients and with each other?
So I can tackle it, Sasha. So, I think one of the reasons I like to show registry data is that when you have a registry data or you have the single ventricle reconstruction trial, there's a core lab, and the core labs are going to measure things the same way every time. So that data I showed you, I really believe that data because it's reliable and it's a core lab. And so that data really has helped me in my practice. So those studies I showed you, that's one thing. The bigger problem is that often if you go to the same center, hopefully they have similar protocols that they're always going to follow the same way, Sasha. And that's the best way I feel is to try to control for those things. We're all busy though, as you know. You may read my echoes one day and I read your echoes the day, but if the protocols of what we're going to measure every time is the same, my opinion is that's the best way to control for these things. But as I said, heart rate, volume status, did they take their meds? Oops, I forgot my meds. I drove 2 hours to get to my clinic. All those things matter when we're measuring these things. And so it's hard. So I think two things, same protocol at your center. So you're getting the same measurements every time is probably the key. And then again, trying to do it in the same physiologically state is probably the best. So I know you deal with this too, Sasha. So it's a challenge, right?
Yes. And I think it's the communication that's a little bit difficult because it's sometimes disconcerting to hear, oh yeah, mild to moderate's the same as moderate, the same as mild, depending on the day and the mood of the person who's reading the study. But I think the reality is that not only there's variability within and between observers and within the patient, and the study itself is not a very precise way to measure regurgitation, and we can't just do an MRI every time. So I think it is very challenging in trying to make sure that we communicate that amount of uncertainty while still making clear that we do understand the bigger picture. It's a hard balance.
I will, just for everybody to hear, is just I'm a simple thinker, believe it or not. And so like mild doesn't mean much to me. Severe means a lot to me. And so a lot of people are in between, right? And so in my mind in the echo lab, determining if you're closer to the severe or closer to mild is how I often think about it. Mild is something that is not that hard to figure out versus severe. It's not very hard to figure out. It's the ones in between. So I don't know, Sasha, that's how I kind of approach the day, especially when it's a busy day. Those are kind of the ways I think about it.
I think part of the question too was about the difficulty for the parents. And I think it's hard. It goes without saying, and maybe Lacey can comment on this too, but we just have to be really transparent about the family, which what we can and can't do. And that's exactly like Mike said. Listen, I know what mild is and I know what severe is, but we don't really know a lot in the middle. And what I always tell the parents too is don't get hung up on any one number. Like what is the transformative gradient, or what is the PA pressure? What's the cutoff? Where are you not going to do Fontan? Well, there really isn't a number, but they're very difficult concepts, but it's easy to pick a number or a word like moderate. But I try to tell the parents it's not about that. It's not about any one number. It's not about any one word. And for me as a surgeon, I'm even more simple. It's either I fix it or I don't. So that's really what it comes down to me. I look at it, I'm like, I either got to fix that or I am not going to fix that.
Yeah, I mean, I'm reasonable to the fact that, there's inherent limitations with the echo. And like Sasha, you said, you can't just MRI everybody. But yeah, I think that parents, and patients themselves, I can imagine, just want to know when to start to worry or when to start to making their contingency plans or when to go down just different pathways. So I think, yeah, well, I totally get it that it's like you're either okay mild or you're like, we need to do something severe, and it's hard to really tease out the middle. I think the more that we can do that when it's possible, then just allows people to kind of be prepared for what's coming down the pike.
It's a very, very fair.
Dala Zakaria from Arkansas. So that was a great talk. Thank you very much. But I have a question. What would you do for a 10-year-old coming to your Fontana clinic who playing baseball, looking great, and the echo read as moderate to severe, again, moderate some days and severe some other days, with a mildly dysfunction RV? I mean, are you going to send him for surgery, worrying that this is going to progress? Are you going to just watch him and wait for the RV function to get worse, and then we know the outcome going to be bad? So what is going to be your threshold to send for surgery?
Yeah. Well, first of all, I'd say swing for the fences when he's playing. So he's going to play baseball. I would let him. So I think, again, those are hard cases that we all deal with. But it's not one factor, right? If he feels well, his quality of life is good, his exercise tolerance is good, he has regurg, but his function is okay. But you said mild reduced. Again, that's often hard to actually say if it's mild, moderate, severe too. So then you use all your parameters. In general, I would not send him to having surgery, in my opinion, but I would try to maximize things the best we could. And I would try to risk stratify him with all those things. Remember, exercise tolerance is not just the AV valve. It's not just a function. Like I said, our patients have restrictive lung disease. You have sternotomies, thoracotomies. The chest wall is really stiff a lot of times. And one thing I didn't show in my favorite slide, and I didn't know if I'd have time today. Everybody in this room, if you look at all the medication studies, I could put hundreds of them. Dr. Rychek could put hundreds up there and show you the micro differences in medications that make in Fontans is small. So we don't have the holy grail. But the number one predictor and the one that improves everything the most is exercise. And so there's a graph in a study that I show that you look at some of these rehab programs, you look at some of the exercise programs, that makes the biggest difference. And you'll see the biggest gains in everything from their functional capacity just with exercise. And it's a slide that I use all the time because it blows away any of the medical data we've ever published. So just another thing. So the answer is that I would let him play. I would risk stratum him the best I could. I would not send for surgery. But again, without all those factors, it would not be just the valve leakage that I would go by.
Thank you.
Yeah, I would agree that it's a lot of things. I mean, you have to look at everything. And from a surgical standpoint, you know, I think the other factors that go into it for me is how repairable is the valve. If I look at it and it's like, oh, it's annular dilatation, and I think there's an extremely good chance I'm going to go in there and have a quick fix and it's going to get better. As far as your individual patient, I think at Michigan we would consider doing that kid's heart surgery because he does have a little bit of RV dysfunction. I don't know if it's by MR or by echo, but it is a hard thing to measure and to define, admittedly. But I'd be a little concerned, especially if he was normal all his life and now he's had even the smallest downturn. I think we would intervene on that patient. But again, it depends on a lot of other factors too. And I agree 100% with the exercise thing. We have our exercise program for our single ventricles, super important, better than any other med or surgery you could have.
I think we have 5 minutes left if we have enough time for another question, perhaps.
Hi there. I'm a parent. My daughter is 4. We had a TR repair done at her Fontan, which has failed. And what we've always heard, she has great heart function, ventricle function, is that typically second repairs, if the first one doesn't work, a second one isn't going to work. Is that your experience or any thoughts there would be appreciative?
Well, as I learned from those of you know, Dennis Crowley, one of our cardiologists, it depends. That's what he always would say. It depends. It would depend on what it looked like, what I saw. If I was the person that did the first repair, what I did, what I saw. I don't think a second repair is by definition bad, but certainly your best shot is the first time. And I would ask the surgeon what they did, what they saw, or happy to look at the echo for your daughter as well.
There's some really, really cool studies that I didn't even put up here because of time, but they've MRI'd and they look at the way the valve is curved, it's saddled. They measure the distance between the leaflets and the AV valve cords. They actually look at the elliptical surface and they find as over time in adulthood in particular, the valve actually dilates and it dilates closer towards the septum. So the length from the septum all the way to the wall increases and that causes the leakage. So there's a lot of what ifs that really go into the mechanism. So the mechanism when you're at Glenn may completely be different when you're past the Fontan. And so all these things, and there's some beautiful studies showing that, very technical, but it was a really fascinating study to see what happens to the valve, the tricuspid valve over time. And that mechanism completely could be different based on the time or where you're at in your journey.
Are there any other questions? No?
Thank you, everybody.
Yeah, thanks very much. I appreciate everybody's time.
Thank you to our panelists.